Good evening and welcome to Infants Nutrition webinar series. The theme for this educational webinar will be the Allergy Expert in Action, Alexa. This webinar is offered by Sespagan and is supported by Nutricia Specialized Nutrition. This webinar has been accredited as 3 CME points by the Saudi Commission for Health Specialties in Saudi. Since this is a CPD accredited event and as per the accrediting organization requirements, please note that credit certificates will be provided only to those who participated fully in the activity and completed its requirements. If a participant failed to attend the activity in full, then he will not be eligible to receive credit points assigned for that activity. Few days after the webinar, you will receive a feedback form to fill up, as your opinion is very important to us, and it will give you access to your CME certificate. Let's start with this evening's program. This webinar will take the format of 2 individual presentations delivered by our guest speakers and will be followed by a dedicated question and answer session. You have a chat tab that you can use, but please submit your questions using the question tabs that you can see on the right of your screen during the presentation. You can send your questions while the speaker is presenting. The speaker will then reply to as many questions as the time will allow. During the presentation, we will post poll questions. Please reply to them in the poll tab to the best of your knowledge. To start this webinar, we would like to welcome our first speaker for this evening, Dr. Ali Almehaidib. Dr. Almehaidib is a consultant and pediatric gastroenterologist at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. Without further ado, let's welcome Dr. Almehaidib to join us. Dr. Almehaidib, up to you.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Helen, for this nice introduction. And I am very pleased to participate in this webinar. I would like to thank the Sasbigan Scientific Committee for inviting me for this presentation, as well as Nutricia Company for sponsoring this activity. Today I'm going to talk about the health consequences of cow's milk allergy. As we know, cow's milk allergy is seen now in our practice. I have started with this poll about the prevalence of cow's milk allergy worldwide. Is it 0.5 to 1%? 2 to 5%, 15 to 20%, or 30 to 40%? Can you answer, please? Okay, so we have here the right answer was, answered in 56% of the participants, which is 2 to 5%, followed by 15 to 20% in 31%. I think this is a good start because, allergy is increasing rapidly in developing countries. Worldwide, it is up to 30 to 40% in general. This is food allergy, and in infants and children up to 5 to 8%. However, cow milk allergy is seen in 2 to 5% worldwide. So we are seeing more of cow milk allergy these days as compared to a few years back. What is the prevalence of allergic diseases in general in some of the GCC countries? As you could see from this slide, we are not away from the worldwide, prevalence. In Saudi Arabia, asthma is, the most common compared to other countries with 23.6%, and the lowest is in Kuwait. However, Kuwait has more allergic rhinitis of 2% as compared to 10% in Oman, for example. Eczema also is ranging from 10 to 14%. However, it is more common seen in 22.5% in Oman. So in general, we are seeing same figures as compared to other countries in different parts of the world. The rise of cow milk allergy, there has been a trend toward increasing incidence and prevalence, increasing persistence into school age and beyond, and increasing severity and increasing rate of hospitalization. In this cohort of Italian children, they have, noticed an increase in the admission, or hospitalization for food-induced anaphylaxis, as compared to like 8 years ago, with a huge increase in different age group, more increase in 5 to 14 years of age, which is alarming. This is a very common, picture we see, which is called atopic marsh, where allergies early in life predispose subject for having other secondary allergies later in life. And this is known as a concept of atopic marsh. And this, schematic representation of symptoms according to age. Once a child has developed atopic dermatitis or a food allergy in the first years of life, the child is more likely to develop other allergies like allergic rhinitis or asthma later in life. And this has a lot of implication on the future of the society and the burden on healthcare services. So the burden of allergy goes beyond symptoms. If you think of it from different angles, then it has been linked to an increase in risk of future non-communicable diseases like heart disease, obesity, etc. It has a psychological impact on the child and parents, and it will also affect the quality of life of the family. Consider a child who has allergy presenting with different symptoms. He's not sleeping, he's crying, he's vomiting, he's feeling the rectum, etc. And this will lead to a lot of consequences in accordance to the family structure and in relation to the mother, especially if she is working. Also socially, they are isolated. They have frequent visits to clinics, frequent visits to hospitals, and they are afraid of future health problems. As people are reading now in the internet, and they link this atopic marsh. When they read about it, they anticipate that they may have allergic diseases in the future. Also, it has, we are in the era of cost containment, and it has an increased medical health and indirect costs, which will be discussed later in this presentation. Let us see this ball now. Growth in cow milk allergy patient is A, always affected, B, sometimes affected, and C, never affected. So let us answer. I'll give you 10 seconds maybe. Okay, so 90% answered, sometimes affected, and 13% or 12% now answered always affected. In medicine, almost always, there is no always and there is no never. The chance, even in MCQ, if you see always or never, it is likely to be wrong. So growth is affected sometimes in these patients. And if you see, failure to thrive or growth faltering in these group of patients, the prevalence of stunting in the food allergic community has been described in 9 to 14% in developed countries, and in 20 to 25% in non-IgE-mediated, patients in developing countries. As we, discussed before in previous, presentations, stunting does not have effect on long-term height of these, affected children, but it affects the whole community because it is linked to poor cognitive outcome later in life. So if you have, patients, or children who are stunted, as infants and young children, then the likelihood they will be after 20-25 years functioning very well in the society is reduced, because they have some poor cognitive outcomes during this period. So we have a lot of challenges in the management of food allergy in children. As you know, the type of food eliminated is important, and the number of food eliminated is important. I have seen a patient recently who has cow milk allergy, and the father was concerned about his growth, and we discussed with him because of elimination. This father was very strict with elimination, and which has led to unwanted consequences. So elimination of diet and inappropriate food replacement, reduced variety of food will lead to growth failure, and this will also include micronutrient deficiencies, and this will be a vicious cycle, especially patients who have atopic comorbidities. So the height in particular is affected in cow milk protein allergy patients, and the identified cofactor is the atopic dermatitis. This is a study by Roseanne Myers. She's a well-known clinical dietitian in King's College Hospital, where they have 430 children from 12 allergy centers all over the world, almost all continents, South America, North America, Africa, Europe, and Asia. And the median age at diagnosis and data collection was 8 months and 23 months, respectively. And pooled data indicated that 6% were underweight, 9% were stunted, 5% were undernourished, and 8% were overweight. Furthermore, cow milk elimination led to lower weight for scores than other food elimination. And mixed IgE and non-IgE-mediated allergy had lower height for age Z score than IgE-mediated allergy. And children with only non-IgE-mediated allergies had lower weight for height and body mass index. Atopic comorbidity did not impact in growth in this study. So the author concluded that stunting is more common in children with food allergies than low weight. So it affects more of a height. And children particularly at risk of poor growth are those with non-IgE and mixed IgE and non-IgE-mediated allergies, as well as those with allergy, you can see from this table. Another study by the same author about the impact of elimination diet on growth and nutrient intake in children with food protein-induced gastrointestinal allergies, where they recruited 130 children, and almost all children, almost around 95% in this study, eliminated cow milk from their diet, and average contribution of energy in the form of protein was 13.8%, from carbohydrate 51.2%, and from fat is 35%. So they have seen 9% were stunted and 2.8% were wasted. So it has effect on the length rather than, or the height rather than the weight, more on the height. There was a statistically significant improvement in weight for age after the 4-week elimination diet. And the elimination diet itself did not improve any of the growth parameters, but achieving energy and protein intake improved weight for age and weight for height, respectively. On the other hand, vitamins and mineral supplementation and hypoallergic formulas were positively associated with weight for height and weight for age. So they concluded that with appropriate dietary advice, including optimal energy and protein intake, hypoallergic formula, and vitamin and mineral supplementation, growth parameter increased from before and after dietary elimination. And these factors were positively associated with growth, irrespective of the type of elimination diet and the number of food eliminated. And this, another study from Erica Isolari, which is a well-known figure in this field, which she had 100 children with a mean age of 7 months, and there was a fall in length which coincided with symptom appearance of cow milk protein allergy and also with elimination diet between 3 and 12 months of age. So when should infant with cow milk protein allergy use amino acid formula? There are multiple studies, and this is a controversial issue. However, in multiple studies, they have shown height for age was significantly higher in infants on amino acid-based formula. However, in some studies, there was no significant difference in length, weight, head circumference between these groups. And these two studies have shown that patient, failed on extensive hydrolyzed formula, and they have done better on amino acid-based formula, especially when we are talking about length. This is the SBIGAN guidelines. For the use of amino acid-based formula, it may be considered as first-line treatment despite limited evidence in infants with severe anaphylactic reactions and infants with severe enteropathy indicated by hypoproteinemia and faltering growth. So this is the statement from SBIGAN. So the appropriate use of amino acid-based formula is highly debated topic because there is a significant burden either the healthcare system or to the parents. From the literature, the following themes were identified as possible reasons for choosing an amino acid-based formula. If you have symptoms not fully resolved in extensive hydrolyzed formula, and this is according to the guidelines. If you have faltering growth and failure to thrive also. If you have multiple food eliminations, if you have severe complex gastrointestinal food allergies, and if you have xenophilic esophagitis, if you have food protein-induced enterocolitis syndrome, severe eczema, and symptoms while breastfeeding. So each of these themes were critically reviewed using all available, published data, and found that using an amino acid-based formula in high growth faltering may be indicated. So this is one of the important, indication for using amino acid-based formula. The others are still on debate. Some of may recommend using amino acid formula. Some may recommend using extensive hydrolyzed formula. So if you have an uncomplicated cow milk protein allergy patient, they may not respond to extensive hydrolyzed formula in which percentage? Patient who has cow milk protein allergy, they were given extensive hydrolyzed formula. What percentage will not respond to extensive hydrolyzed formula? 3%, 10%, 25%, and 40%. So we have 50% answered 10. Now it is dropped to 47, 44%, and then followed by 3% and 24%. So the answer is 10% in these patients. So 10% of uncomplicated cow milk allergy and up to 40% of infants with more complex allergy may be intolerant to an extensive hydrolyzed formula. So persistent of symptoms while seeking a diagnosis with an extensive hydrolyzed formula. As you could see, the only formula effective to be used as an aid to diagnosis is amino acid formula. If you have a patient suspected of cow milk protein allergy, then you use extensive hydrolyzed formula. There is no response after 2 to 3 weeks, then you may shift to amino acid based formula and This may give you, a clue for both diagnosis and treatment. And this, in this study, it was very clear that, faltering growth with multiple other atopic symptoms is contributing, especially patients who have severe GI symptoms, who have multiple allergies, and who have atopic dermatitis. Their growth, will be affected, especially their height. Let us discuss, symptoms while breastfeeding. If you have a mother who's breastfeeding and the baby developed, symptoms which is suggestive of cow milk protein allergy, then let us see this, poll. In a 3-month-old breastfed infant with cow milk protein allergy, the best initial approach is A, continue breastfeeding while eliminating cow milk product from maternal diet. B, stop breastfeeding, start extensively hydrolyzed formula. C, stop breastfeeding and start amino acid formula. And D, stop breastfeeding and start soy protein formula. So what is the best answer in your opinion? So 96% answered the right answer, which is, I'm very happy that we answered this. Continue breastfeeding while eliminating cow milk products from maternal diet. And this is the important, you don't stop breastfeeding just because the baby has, possible diagnosis of cow milk protein allergy. So breast milk remains the criterion standard source of nutrition for young children with cow milk protein allergy and should be promoted whenever possible. And I must, emphasize this. Although beta-lactoglobulin originating from cow's milk can be detected in breast milk of 95% of lactating women, the amount is insignificant to many of the infants with mild to moderate cow milk protein allergy. However, some children with cow milk protein allergy are more sensitive to residual cow milk protein and may react to the residual of beta-lactoglobulin transferred through breast milk. So, continue breast milk and observe the child. Myers also published that in delayed non-IgE-mediated group, 16% settled on maternal elimination diet, those who are breastfed, 17% settled on an extensive hydrolyzed formula, and 38% required an amino acid formula. Van der Hoef, who is a well-known pediatric gastroenterologist, he is one of the authorities in the 90s, and he had very interest in chronic diarrheas especially, and he published that 29% of children who failed an extensive hydrolyzed formula improved on amino acid-based formula, exhibit symptoms while breastfeeding. So this was published as early as 1997. And Myers also published about a cohort of children, the number is low, which is 14, who continued to have symptoms of proctocolitis in spite of maternal elimination. All 14 were switched to an amino formula and improved. However, they did not try extensive hydrolyzed formula, and it is difficult to establish whether they would have tolerated, the extensive hydrolyzed formula or not. In addition to the use of amino acid formula, all patients were in multiple food elimination diets, so this may have contributed also to their improvement. Let us take this poll. A 3-month-old breastfed infant with cow milk protein allergy has a hemoglobin of 7.9 gram per deciliter. The most likely cause of his anemia is A, iron deficiency, B, folic acid deficiency, C, vitamin B12 deficiency. Okay, so majority answered the right answer. It's iron deficiency anemia, almost 90% of the attendee, which is also good. So iron deficiency is common in patients with cow milk protein allergy. As you know, the reactions in consideration to cow's milk allergy include a lot of clinical presentation. One of them is, chronic diarrhea, stool in blood, and iron deficiency anemia. And, cow milk protein allergy should be considered in young children with undetermined iron deficiency anemia. And cow milk's protein elimination and iron supplementation help in the recovery. Allergic disorders of the GI tract can be associated with malabsorption and loss of protein and iron from the GI tract. This may occasionally result in iron deficiency anemia that must be treated along with the strategies to limit antigen exposure to induce tolerance. Usually, we supplement, these patients with iron for a short period. And once, elimination therapy has been started with hypoallergenic formula, then patient, will respond. Their hemoglobin will normalize in a few weeks. Let us talk about the economic burden of cow's milk allergy. Does it affect the economy? As we know, if you invest in health sector, this will promote or inhibit economic growth. In this study, the findings suggested that in addition to their long-term benefits, investment in health sector, such investment may actually have short-term positive growth effects that make that recovery more likely. And as you know, investment in health sector is investment in the society. In addition to that, investment in education of the society. So the disease burden is significant. We can identify 4 areas of the burden of cow food allergy and cow milk protein allergy. Number 1, the prevalence of food allergy worldwide is rising dramatically in both developed and developing countries. Number 2, allergies are now considered the most common chronic disease of the 21st century. Almost 49% of the pediatric population has allergic symptoms. Number 3, the patterns of cow milk allergy is becoming increasingly aggressive. And number 4, allergic disease reduces the quality of life of both patients and their families. Let us talk about the first, burden. As you know, the prevalence, as we discussed earlier, is increasing dramatically. And by 2025, more than 50% of all Europeans will suffer from allergy. And by 2050, allergy will affect up to 4 billion people globally. And we are seeing now rapidly increasing burden in developing countries. Maybe this is contributed to the hygiene theory, etc., etc. And food allergies affect up to 8% of infant and young children globally, with cow milk being the leading cause. The other burden is that the allergies are now considered the most common chronic diseases of the 21st century. And, including, allergic rhinitis, allergic conjunctivitis, asthma, atopic dermatitis, and food allergy. And the most common food sensitizing in early childhood is cow milk. The third burden is aggressive pattern of the disease, where you have a trend toward increased incidence and prevalence, increased persistence into school age and beyond, increased severity and increased rate of hospitalization, as I mentioned earlier about this Italian, report with increasing hospitalization of food-induced anaphylaxis, especially in children between 5 and 14 years of age. What about quality of life? I'm sure, as healthcare providers who are working with pediatrics and especially infants, it has a major impact on the quality of life of the parents and the child. They don't sleep. They have frequent symptoms. They spit up. They have bleeding per rectum. They are not growing, etc., etc. So it has many aspects of our impact on the families, and maybe Dr. Wajeeh will discuss later on some of these aspects in the case presentation. So let us answer this question. Challenges in diagnosing non-IgE-mediated cow milk protein allergy include. Maybe we'll ask Dr. Wajeeh to participate here. No single reliable test available for non-IgE-mediated allergy. B, delayed symptoms onset in mild to moderate allergy. C, overlap of symptoms with many other diseases. And D, long, lengthy road to reach a diagnosis. So which is the most likely challenge in your opinion? Okay, so Dr. Wajeeh, do you see the polls on the right side?
Yes, I do, Dr. Ali. It seems that this is a trick question.
We
all answers are correct. Can you hear me now?
So?
Yeah,
So
I think this is a trick question.
57% answered A, no single reliable test available for non-IgE-mediated allergy.
That's right.
And
I believe
0% for D, long, lengthy road to reach a diagnosis.
That's right. I think this is.
Think
I do believe all the answers are correct.
Mm-hmm.
I think there maybe E, all of the above.
All of the above. I think that's right. With variable, importance, but all these four, answers are correct. So there are no single reliable test available for non-IgE-mediated allergy, and this will lead, to a lengthy road to reach a diagnosis. And delayed symptom onset with generalized and diverse manifestation, especially in mild to moderate symptoms, and overlap with symptoms of many other diseases, making a differential diagnosis time-consuming, long and invasive and costly. So all of these factors are challenges in diagnosing non-IgE-mediated, which has a very important impact on the patient and on the family, from both psychological, financial, etc. So delayed diagnosis, prolonged distress for infants and their parents. In the side of the slide, it has shown that patient has 4 months average time to make a diagnosis and more than 18 healthcare visits per patient, which is huge. That's why we need to talk about this disease and try to increase awareness about disease in order to reach to diagnosis as early as possible. As you could see on the left side of the slide, an earlier diagnosis reduces treatment length and cost of cow milk allergy management. So infants diagnosed less than 6 months average 8.2 months on amino acid based formula, and early diagnosis will decrease cost. However, if they are diagnosed more than 6 months, the average of 17.2 months on amino acid based formula and late diagnosis will increase the cost. So it is very important to recognize the disease, diagnose it early, and start treatment early in order to decrease the cost. This, very important, guidelines published by SBGAM, GI Committee in 2012. They have mentioned that clinical assessment with cow milk protein elimination and challenge remains fundamental for the accurate diagnosis of cow milk protein. What about budget? People are talking now about money, and money is affecting our life in different directions, especially in our practice nowadays. In UK, in 2010 they reviewed 1,000 infants with cow milk allergy from the primary care database. 86% were first diagnosed in primary care, and the majority remained there for their care. 42% of infants were referred on usually to the care of general pediatricians, and only a few were seen at a specialist level multidisciplinary pediatric allergy service, and the majority presented clinically with mild to moderate symptoms of suspected non-IgE-mediated cow milk allergy. And the review highlighted the evidence of under-recognition, misdiagnosis, significant delay in diagnosis, and suboptimal management of the infants, especially in choosing the most appropriate initial alternative formula suitable for the management of cow milk allergy when breast milk is not available. I have seen a report today which was sent to me as a referral from one of the peripheral hospitals, and they have mentioned the patient was suspected to have cow milk allergy, and the patient in goat milk which is not the right statement. If you have suspected, cow milk allergy, you should not use goat milk, because goat milk is not used for allergy. It is used for intolerance or other indications, but it is not used for. This is one of the mistakes that some of our colleagues may think that goat milk will treat allergies. In 2017, the authors described indication for different formulas for diagnosis and management of cow milk allergy based on consensus of national and international guidelines. And it's very important to indicate that extensive hydrolyzed formula continues to be recommended as the initial prescribed formula for most infants presenting with suspected mild to moderate cow milk allergy. However, worldwide, there is at least one example. In China, they use amino acid-based formula as the initial diagnostic trial formula in all suspected cases. Maybe they have money now and they can use amino acid-based formula for that reason. But it is not the current, guidelines. However, guidelines may change with more data in the future. So, what is the efficacy of amino acid formula in relieving the symptoms of cow milk allergy? If you have a cow milk protein allergy patient, the extensive hydrolyzed formula tolerance between 2 and 10% of uncomplicated cow milk protein allergy. And it can increase to 40% in children with symptoms persistent while with breastfeeding, non-IgE-mediated GI symptoms, gastroesophageal reflux, enterocolitis, proctitis, and gastroenteritis, and severe atopic eczema. Most of these children have other food allergies. So it is important to recognize that some patients may react to extensive hydrolyzed formula, and you need to make sure that you are dealing with the right formula. What about the economic impact of childhood food allergy in the United States? As you could see from this slide, the cost is huge. $24.8 billion US annually. The child is costing $4,184 US per year. It includes direct medical cost, clinician visit, emergency department visit, hospitalization, and childhood food allergies cost U.S. families $20.5 billion annually, averaging same $4,184 per child per year, including lost labor, productivity, out-of-pocket, and opportunity cost. So infants with cow milk allergy have a higher risk of exhibiting more allergies like asthma in the future, as we mentioned earlier. So in symptoms, in uncontrolled cow milk allergy, drive parents to their general pediatrician, GPs or pediatrician. 6 out of 10 infants present with eczema and GI symptoms, and other symptoms present like gastroenteritis, crying, reflux, constipation, in more than 5% of infants presenting to their GP. So this is not something small. And it can take some time before these symptoms to diagnosis and effective nutritional management. And the treatment used to manage symptoms, as you could see, 1 in 3 they use topical dermatological treatment, especially for atopic eczema. 1 in 5 they use GI medication, antacid, laxative, PPI, H2 antagonist, and 1 in 8 used antihistamines. And EpiPen was used in 5% of those presenting with urticaria. So this is a huge, impact on the health system using these medications, which may be not necessary, since establishing an effective clinical nutrition solution quickly is important to reduce the burden of uncontrolled cow milk allergy. And this slide is showing you the real cost in some of these countries where this scheme is to reduce time to diagnosis, time to treatment, and time to symptom resolution could decrease this burden, which is the economic burden. So it is very important to pick up these patients and diagnose them and treat them appropriately as early as possible. The use of amino acid-based formula can help during the elimination phase to ensure conclusive diagnosis. Although I mentioned earlier, this is some controversial issue. But if you have false positive diagnosis, will continue to undermine reliable evaluation of the nature or natural history of the disease, leading to an overestimate of the condition. So this is sometimes you may overdiagnose patients. And epidemiology of cowmilk allergy has not been completely elucidated, and there is some evidence that a relatively high number of children are over-treated with unnecessary elimination diets, with all the struggle with elimination diet these children is having. And amino acid-based formula allows the complete removal of the suspected allergen from the diet, thereby permitting a reliable diagnosis. So sometimes you might have a false negative diagnosis. Highly atopic infants continue to react to an extensive hydrolyze during elimination of diagnosis, and further period of assessment using an amino acid base is not undertaken. A diagnosis of cow milk allergy may be improperly ruled out. And as I mentioned earlier, SBGAN recommend if multiple food allergy is suspected in highly atopic children, then exclusive feeding with an amino acid based formula may be considered to allow symptom improvement before oral challenge with cow milk protein is performed. In this study, which was published in Journal of Medical Economics, they concluded, that using an amino acid formula in the elimination diagnostic diet followed by an oral food challenge is a dominant pharmacoeconomic approach that has a lower cost and result in increased number of symptoms-free days. And this is now being, discussed in the literature, whether you need to use amino acid, more aggressive amino acid-based form, more aggressive than our current practice, in order to reach, early diagnosis and early elimination of symptoms. And the guidelines, and the consensus approach is that if an infant fed with strong suspicion or very generalized symptoms, then start elimination diet using extensive hydrolyzed formula for at least 4 weeks. If symptoms do not resolve, change to amino acid-based formula and continue for 4 weeks. If there is no resolution, then this is not cow milk allergy. So we think of other possible diagnoses. If symptom resolves, then it is cow milk allergy confirmed. However, there is a new approach about using amino acid-based formula, where it support earlier diagnosis, earlier resolution of symptoms, minimize the plight of parents, really not more expensive, and nutrition has no harm from a nutritional point of view, and it is a win-win situation. So without further delay, I would conclude that the fiscal impact of investment in the healthcare is positive. Only one other sector carries a more positive impact, which is education, as mentioned earlier. And cow milk allergy induces a significant direct and indirect burden on patient and families and healthcare system. A prolonged journey to diagnosis of cow milk allergy has dramatic cost impact, which can effectively be effectively reduced by earlier diagnosis, reducing time of the initiation of treatment and reducing time to relieve the symptoms. And the amino acid-based formula used during elimination phase for cow milk allergy may be able to reduce burden of disease and cost impact on cow milk allergy and require clinical consideration depending on where you do practice and what are the available resources in the community you are practicing. By this, I would like to thank you and stay safe. Thank you very much.
Thank you, Dr. Almehaidib, for this insightful presentation. Please join us back for the Q&A session at the end of the presentations. Now, please help me in welcoming Dr. Wajeeh Aldekhail. Dr. Aldekhail is a consultant in the pediatric gastroenterology and transplant hepatology department unit at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. It is our pleasure to welcome Dr. Aldekhail to join us. Dr. Aldekhail, up to you.
Assalamu alaikum wa rahmatullah. Good evening, everyone. Thank you, Helen, for that kind introduction. And also thank you to the Scientific Committee in Saspigan for their kind invitation and giving me the opportunity to participate in this webinar. Also, thank you to Nutricia for sponsoring this event, namely Dr. Sahir mostly. So I'll be going through a couple of cases during this presentation. I hope I will not take long. These cases will hopefully be in complement to what Dr. Ali Almehaidib presented about the burden and the consequences, the cost impact of cow milk allergy in the area. This is my disclosure. We as pediatricians are advocates for breast milk and breastfeeding. And breast milk is considered as the primary source for nutrition in newborns. In addition, it's the gold standard for optimal nutrition in health and disease during infancy. And we won't be seeing a cow nurturing a child and holding a baby and feeding him the bottle. So I'll start off the first case. A 3-month-old baby who presented with pallor and generalized body swelling. She's a product of normal pregnancy. She's full-term and vaginal delivery. On standard infant formula, she was breastfed for about the first 3 weeks of life, and then mother switched her to a standard infant formula. She has been feeding well. During this case, now back to the physical examination. The child was pale, she was not jaundiced, there was generalized edema, she had no skin rash, and the rest of her examination was normal. So given that this case now, you have a child with generalized body edema, what would be your next step? Would you do a urine dipstick, serum albumin, do a CBC and differential because she's pale, or do an albumin tagged scan? So the majority of votes, around almost about 45%, are saying to do a serum albumin to assess is this generalized body edema is related to having this edema is due to hypoalbuminemia. Urine dipstick is a good answer. You might 37% said to do a urine dipstick. It's very simple. You can do it bedside and assess if this child is losing albumin through the urine. Now, in fact, when you looked at the urine, it was negative for protein. The serum albumin was 10. And she had a hemoglobin of 7.5, which was low. And the second step was considering the albumin tagged scan after that, seeing where is this child losing, since there's no loss through the urinary tract. And she was feeding well, she was thriving well, and would be looking at the gastrointestinal tract. The albumin tagged scan was positive. You can see the increased uptake in the bowel. So this patient was started on ferrous sulfate because of the anemia, in addition to an extensively hydrolyzed formula. And she had a follow-up visit about 4 weeks later, and the edema disappeared. The hemoglobin was increased to 9.8 grams per liter, and her albumin improved dramatically to 33. If you recall, on initial presentation, it was only 10. So she was labeled as cow milk protein allergy, and the reasons, protein losing enteropathy in children can be caused by cow milk protein allergy. And as Dr. Ali was mentioning during his presentation about some of the consequences, iron deficiency anemia may be a sole manifestation of cow milk protein allergy, and this was reported in hematology back in 2006. In addition, Ivan van den Plas also published the paper on some of the common presentations of cow milk protein allergy, and were mainly related, one of the initial presentations was chronic iron deficiency anemia. Also, protein-losing enteropathy can be seen with severe atopic dermatitis, even in exclusively breastfed babies, and it also can be associated with other allergies to other food components like eggs and others. Okay, let's go to the second case. This is a 2-month-old baby. She presented with vomiting, which started at 2 weeks of age. It was non-bloody, non-bilious. She was feeding well on standard milk formula. There was no fever, diarrhea, or skin rash. She passes stool about 1 to 2 times per day. She's a term baby with a birth weight of 2.9 kilos. And physical examination was unremarkable. Her weight was 3.8, so she gained at 2 months of age. So at this stage, this mother is coming to you with this complaint that her child, this is a mother who, this is her third child, so she has experience with dealing with children. She comes to you complaining that her child has been vomiting almost 50% of his feeds. So if he feeds anywhere from 6 to 8 bottles a day, he vomits more than half of them. But in fact, this baby is thriving well. So at this stage, what would you do? Would you consider starting him on anti-acid medication, or changing the formula to an anti-reflux formula, or advise to thicken the formula, or reassure this mother with no changes? So it seems the majority are going towards changing to an anti-reflux formula. 32% are saying reassure the mother with no change. Others are saying advise to thicken the formula. Maybe I can ask Dr. Ali, since there's a discrepancy between the votes. What would you think, Dr. Ali, at this stage?
These are possible, answers. However, since this patient is not failing to thrive, I would reassure the mother, maybe ask advice here for, smaller, meals rather than big meals. Thickening formula or changing to AR formula, is not indicated if the patient is thriving. We consider this as physiological, reflux. And for definite, I will not start anti-acid medication.
Okay, thank you very much. I do agree. Reassuring this mother, as this child is thriving well. There's no red flags in the history to point towards doing much intervention. Reassurance that this might be most likely is a physiological reflux, and with anti-reflux measures, advising the mother on proper feeding. And again, this is an experienced mother. This is her third baby, and she seeks medical advice because this was not regular for her previous 2 children. So let's see what happened. She was seen by her pediatrician, and in fact, they started proton pump inhibitors. They put her on a PPI of 1 milligram per kg per day, and advised the mother to use smaller and more frequent feeds. According to the mother, the vomiting improved. Instead of having about 4 or 5 times a day vomiting, it reduced to almost once a day, but the baby was still having some vomiting. Symptoms did not improve 100%. But during this time, the baby was still having those symptoms of mild vomiting. He started having colic with excessive crying. Family sought medical advice back to their pediatrician. They were reassured during this age, he's almost 3 months now, that this might be infantile colic. It will, go with time. She was reassured and sent home. 1 week later, still the symptoms persisted. Baby was crying, especially at nighttime. Family went again to their pediatrician, and he advised them to increase the PPI to a BID dose. So that gave the baby 2 milligram per kg per day. So do you agree with this recommendation? Yes or no? So about 53% say no, and 44% say yes, they agree with this recommendation. And I was hoping I would see 100% saying they don't agree with this recommendation, but let's see. So PPIs for crying and irritability is presumed to be attributed to reflux. This was a systematic review of use of PPIs of all the randomized control trials. It showed PPIs for irritability assumed to be related to reflux is useless. And despite the widespread use of PPIs, there is no evidence that reflux causes infants to cry. There is no evidence also that treatments with reflux are ineffective in reducing crying. So this was published in JPGN and Gastroenterology by prominent authors. Okay, back to our patient. So the mother followed the advice of her pediatrician. She increased the PPI to a BID dose. Still no improvement. Her relatives advised her to put the baby or to use simethicone. again, no improvement. She used some herbal remedies, some teas and mixtures which are available in certain pharmacies with no improvement. This was very frustrating for this family. Mother is a working mother. She lost working days. She kept taking excuses from work and sick leaves and so on. So this caused a significant burden on this family. And as mentioned by Dr. Ali, one of the social impact, consequences of these is not only the social issue, but also on the economy itself by losing work, the frequent visits to the physicians, and even medications and prescriptions. So now at this stage, what would you recommend to this mother? She is frustrated. She wants an answer. She increased the dose as the recommendation. She gave her baby herbal remedies with no improvement. Would you assure this mother that this will go away? Prescribe probiotics, a trial of an extensively hydrolyzed formula, or do an abdominal ultrasound? Okay, so I see about 60% are saying a trial of extensively hydrolyzed formula. 15% say just assure the mother that this will go away. And another 15% will prescribe probiotics. Now, probiotics for colic has been studied, and most of the time the recommendations and international guidelines mention that it is mainly for breastfed infants. And this was published in a systematic review in JPGN in 2016. The Middle East expert group recommendations also for the formula-fed babies is to consider an extensively hydrolyzed formula, and even other societies if you think that this might be a cow milk protein allergy. Now, ultrasound, 10% have mentioned that they will do an ultrasound for this child, keeping in mind that sometimes intestinal intussusception or intermittent intussusception may cause these babies to have these bouts of crying, but you might see other features of abdominal rigidity on your abdominal exam, as well as blood, to see blood within the stool. Now, this baby, in fact, was offered to start on an extensively hydrolyzed formula. But prior to starting the milk, the mother saw on the diaper bright red blood with mucus. Now, after she started the extensively hydrolyzed formula, after that, the blood disappeared. The colic as well improved, and the baby, even the reflux symptoms disappeared. So the mother continued, and the baby was labeled, again, as a cow milk protein allergy based on these symptoms. Now, we've seen different varieties of presentations from children presenting with a protein-losing enteropathy, iron deficiency anemia. They may present with reflux as their initial presentation, and even some may present with symptoms of colic. The problem with this is the overlap between those two symptoms and between these two effects. This might be a functional GI disorder of infantile colic. He's at the right age, below 5 months of age. Again, as well, the cow milk protein allergy, these children may present with colic. Now, the 2018 NASPGHAN guideline stated that a 2 to 4 week trial of an extensively hydrolyzed formula or an amino acid-based formula is suggested in infants whom you suspected of having gastroesophageal reflux, as cow milk protein allergy may overlap with symptoms of GERD. And as Dr. Ali also mentioned during his presentation, faltering growth can be affected. These children also may have failure to thrive. It might be one of the symptoms. And in this cohort of patients, 23% of them were diagnosed with gastroesophageal reflux, in fact, and they had cow milk protein allergy. So the recommendations from the different societies when it comes to management of cow milk protein allergy, as we've also heard from Dr. Ali, is the SPGHAN guidelines recommend for breastfed infants a strict cow milk protein free diet is recommended for the mothers. For bottle fed, considering an extensively hydrolyzed formula. The American Academy of Pediatrics, formula-fed infants with confirmed cow milk protein allergy may benefit from the use of an extensively hydrolyzed formula, as well as the SPGHAN recommendations that children, products with a highly reduced allergy based on an extensively hydrolyzed protein is recommended for these babies. And thank you very much for your attention.
Thank you very much, Dr. Wajeeh. We have few questions. Maybe.
So we'll start off with the questions, Dr. Ali. I see a lot of questions coming in.
There is a question about, after child overgrow the milk protein allergy, how can we reintroduce cow milk product? I think this issue was discussed during the previous webinar. Dr. Hassousa has talked about it extensively, and there is a concept of the milk ladder, Sillam. And by the way, at 2 to 3 years, these children usually outgrow the allergy, and then you could go with the ladder and start with small amount of food which contain milk, and then build on that. And the easiest one is cookies and biscuits to start with, and you go from that. I recommend everybody just put in Google, just to say IMAP milk ladder, and you will see it. It is very clear how to introduce. I must emphasize the importance of involving a clinical dietitian when you start to introduce cow milk to these patients. Another question, maybe Dr. Wajeeh, you are expert in this issue. Do we have any clinical evidence about using amino acid formula with HMO in cow milk allergy? Do you want to answer this question?
Use of, I'm sorry, I missed the question.
Using amino acid based formula with HMO in cow milk allergy patients.
Well, So, most of the guidelines recommend use of an extensively hydrolyzed formula. HMOs are additives as a prebiotics. Their function related to immunity and others are well established in the literature. But for cow milk protein allergy, I cannot recall any suggestion from any authority or guideline that recommends its use in addition to a cow milk, to an extensively hydrolyzed formula. If it's there, it's an additive. Probiotics, as I mentioned, it's related to, or the recommendations are those who are breastfed, especially for colic, not for as a use for cow milk protein allergy. It may reduce those symptoms of infantile colic.
Okay, there is another question. What is the appropriate age for introducing weaning food in those with suspected cow milk allergy? The age is the same like other children, but you avoid any product which contains, cow milk. So you introduce it like other, WHO recommended at 6 months, and other societies, including American Academy of Pediatric and ESPIG, and they recommended between 4 and 6 months of age to introduce solids. However, as I mentioned earlier, you need to have a dedicated, clinical dietitian who has interest in the subject, and these patients cannot maintain their life only on milk. They need to have solids, and solids which are free of cow milk protein. The other questions: what is the appropriate time for introducing milk in those with cow milk allergy? Does this differ if they have anaphylactic reaction? Yes. Patient who has anaphylactic reaction are different than patient who doesn't have. As I mentioned, by 2 years of age, most of these patients are going to, outgrow the allergy, and you can introduce milk, as was mentioned earlier, using the milk ladder, or patient who has anaphylaxis reaction, it should be done under supervision with all equipment available with the supervision of an allergist, and this should be done in a hospital setting. So you can introduce cow milk, and you have all settings including epinephrine, etc., in case this patient develop a reaction. So don't take it easy. Anaphylactic shock, in my opinion, anaphylactic reaction means, in my opinion, it means amino acid-based formula from the start, and you introduce milk with consultation with an allergist in hospital setting. Okay, طيب.
There's a good question, Dr. Ali. Does consuming cow milk by pregnant women help to decrease the incidence of cow milk protein allergy in babies?
No.
If I recall, there was a paper published in 2016 in, I think it was in the European Journal of Clinical Nutrition, and it came from Europe, from Finland or UK. In that study, they concluded that high maternal consumption of milk products during the pregnancy, I think it was even in the last trimester, if I'm not mistaken, may protect children from developing cow milk protein allergy. And that was an interesting study because they looked at the IgA. This was a population-based birth cohort, and they looked at the IgA in the cord blood of those offspring. So I think that was an interesting study, but I think this is a very nice question. Probably we'll just need to, from my perspective, I just want to go back and probably just review it and see if there's any more evidence that materialized. This was a study a couple of years back that I read, and probably it will be good to look into the literature to see if there's any more evidence regarding this.
There's a question, can you comment on partially hydrolyzed formula in cow milk protein allergy? Does it have any role?
Partially hydrolyzed?
Yeah, formula.
So the role of partially hydrolyzed formula is no longer. We're now, if you're talking about cow milk protein allergy, the recommendations, guidelines is extensively hydrolyzed formula. And then the second option would be an amino acid-based formula. There is no role for a partially hydrolyzed formula if you're treating these patients. And but even the role.
Is there any role in prevention?
Yes. Now there's a lot of studies that came up and randomized controlled trials, even recommendations that now this has changed. In the past, if you would have probably asked this question maybe 10 years ago or 15 years ago, people would recommend to use an partially hydrolyzed formula or an HA formula, hypoallergic formula for those who have family history of cow milk protein allergy. And I remember in the past, we used to even advise mothers to take a can of a partially hydrolyzed formula with them when she goes for delivery. But now this has changed. The evidence does not support its use, and even in randomized controlled trials, it showed no benefit in prevention.
Do you recommend extensive hydrolyzed formula for all patients having GERD?
No, as I mentioned in the case, and even there, that a trial of 2 to 4 weeks if they do not improve. Now, depending on the age, the onset of symptoms, presence of any red flags in the patient, you have to take them individually. So if there's no red flags, you can assure the mother the child is thriving well, doing anti-reflux measures or anti-regurg measures, small boluses of feeds, as we've, even some of the attendees have answered during the first in fact, the second case. So these are, general steps, but if symptoms persist, and if you are lucky enough to have other features that may suggest cow milk protein allergy, eczema, colic, having bloody stool, and so on, consider an extensively hydrolyzed formula. Even if there is no symptoms, a trial, that's now the recommendations from the SPGAN and NASPGAN, is to give a 2 to 4 week trial of an extensively hydrolyzed formula, as these symptoms may overlap between these two entities.
There is an interesting question here. It's not very clear, but if you have a patient started on amino acid-based formula, severe cow's milk allergy, after starting introducing extensive hydrolyze, he achieved success in tolerance of extensive hydrolyze. يعني بدأ على amino acid وبعدين حول على extensive hydrolyze. 6 months later, they introduced whole protein. Maybe whole cow milk protein, and symptoms came back. So would you go back to extensive hydrolyzed or amino acid based form?
Well, it's difficult because the taste is one factor. Now, babies who have now, if this is after 6 months or 7 months of age, and then going back to a regular formula, the taste will be totally different. It's sometimes very difficult in clinical practice to switch those babies back to either an amino acid or an extensive. But I think, depending on the severity of their cow milk allergy, if they have faltering growth, if there is symptoms that may suggest malabsorption, consider using an amino acid. I would go back to an amino acid-based formula again for that patient. And then wait. Ideally, you would wait until reintroducing, a regular formula after at least 1 year. That's why recommendations now are to wait until 1 year. Because of this concept, switching back and forth between formulas, the taste is completely different. Children will tend to avoid those babies since they tasted a formula which tastes much better than the one that they've been taking for the past couple of months. Now you want them to take them back to that formula again. It will be very difficult. But I think, depending on the symptoms, the severity of it, and according to the question with severe cow milk allergy, I would go back to an amino acid. And I'm sure those symptoms would probably have reoccurred, immediately after the reintroduction.
I think by this we need to conclude because of timing, and we are a little bit late, especially in our colleagues from the Eastern Province. They are going to midnight now. And I would like to again thank SASPIG and Scientific Committee for the invitation. I'd like to thank Nutricia for sponsoring, as well as Modern Medicine for technical support. I'd like to thank my colleague Dr. Wajeeh Aldekhail for an interesting presentation. Thank you very much. Wajeeh, if you have anything to say.
Yeah, thank you very much to everyone. I hope everyone managed to listen to the presentation in full and enjoyed the both presentations. And thank you, Dr. Sahir and Nutricia, for your efforts in sponsoring this event. And thank you everyone for your attention, attendance, and for those valuable questions.
We would like to take this opportunity to thank both our speakers for their time this evening. We would also like to thank you all for taking the time to attend, especially in such uncertain times. We would also appreciate your feedback on this session to help us develop and refine future sessions. Meanwhile, thank you all for attending and take care.